welcome back to this special edition of the Dental Guys here live at the AO meeting in Charlotte, North Carolina. And Wes, I mean, again, just to kick off the opening symposium, we've had kind of two, I would say, game-changing, amazing talks that we've gotten to listen to. I mean, this has been quite a start.
If you're not here, we're bringing it to you now.
That's right.
And what a pleasure it is to finally be able to kind of go back to the year 2000 when the first report on oral health came out, and it said that overall health from the Surgeon General of the United States of America is related to, right, oral health.
Mm-hmm, sure.
I mean, our mouth can affect the rest of our bodies. And I think this collaboration that we're seeing here with the Academy and other organizations and other people is exactly what this is going to be about in just in a few minutes.
Yeah, we've got to be able to learn from others that are kind of overlapping into our field of dentistry and implantology especially. So with that said, we'd like to welcome Edward Schwarz. Dr. Schwarz, thank you for being with us.
My pleasure.
And, there's we put together a bio for you that, we were going to read. And I think for a lot of our listeners are clinicians, are dentists, and they might, some of these things they would go, well, what is that all about? So tell us a little bit about what you do, where you are, kind of what your focus of research is.
Right. So I am a scientist. I'm a scientist because I wanted to be a physician, and then I learned you had to take care of sick people. So that was just not good for me. And it's not as glorious as it looks on TV, as I'm sure you all agree. So at the same time, I went to college right around the time genetic engineering was founded. I took tremendous gravitation towards that and never changed my mind. So I am in the field what is called an osteoimmunologist, which is the interface. I'm formally trained as an immunologist and microbiologist, but my organ system is the bone. So I'm fascinated with all things that are an interaction between the immune system and bone. My personal research is focused on bone infection, which I came here to talk to the AO today about, and I also have a very large program on rheumatoid arthritis flare.
Okay. Well, as you started speaking today about sort of the mechanism, I would call it, of hip implant infections, or that was one of your big focuses today. You started talking about what's actually going on. Why do we see recurrent infections, for instance, after several revisions? Talk a little bit through for our listeners to kind of what are some of those mechanisms? Why do we see, again, repeated failures with, all of these treatment modalities that up till now have been kind of used to try to fix these problems?
Right. So the big discovery that was made by my lab and has moved on in the field is that, to remind the listeners that bone isn't rock. So there are cells actually that live deep inside the bone, which are called osteocytes. And they have these processes that reach from deep in the bone through very, very, very tiny, what we call submicron canaliculi, pores, that are much smaller than cells. And they speak to the surface to tell the surface how much load is on them. So if there's a lot of load, they speak to the osteoblast to make more bone. If there's less load or if the bone is unloaded, they speak to osteoclast to remove the bone. And from a primordial mechanism of pathogenesis, the most virulent pathogens have figured that out. And they figured out a way to invade and squeeze into those holes and invade all the way down in. So one of the commonalities that we have in orthopedics and in oral surgery is we teach to debride to bleeding bone. So once you're bleeding, then you're good to go. That's not the case in this infection because the bacteria they've infected past that margin. And so in many cases, you're now putting a new sterile implant in a revision process right next to the bacteria, and so it rapidly recolonizes. And so with that new knowledge, we have new approaches to defeat the pathogen that we're working on.
So it's basically impossible to sterilize the bone because it is porous.
Correct.
And we immediately started looking at one another and in your lecture today, and we started thinking about how this could work from a standpoint of revisions for our own patients. Mm-hmm. When a patient, we know that right now, if you have a patient that loses a dental implant, going back and placing another implant in that site the success rate drops. And then a third revision, the success rate drops even more, almost 30% failure rate. There's also some literature that shows that post-infection in teeth, we have a problem with root canals. Maybe they've gone bad, or for whatever reason, there's been a large, long-standing infection. We take those teeth out and do a revision to the bone, and then place an implant. The success rate of that implant maybe not as high,
right?
As,
and there's
as a healed ridge.
We knew from our literature that there are specific bacteria that tend to be isolated from, say, those failed sites more commonly. But now it's making us think, could it really be that it's not just specific bacteria, but that this bacteria is latent in the bone? It would make perfect sense based on the same type of mechanism. So that's obviously something that we have a lot of thinking to do about. How does that change our protocols? But let's talk about how it's changed or changing protocols of treatment in your world, because you've been working not only on the discovery of what's really going on, but how could we actually create therapies for this? So speak to that a little bit.
Right. So the approach we talked about today is really twofold. The first is first is knowing which are the virulent friends and foes. Right. So the speaker that came after me talked about the microbiome. These are normal bacteria that live on us. We're only 10% human. We're 90% bacteria. So we need them. They help us. And so having a better knowledge base of who's friend and who's foe. In orthopedics, we work with sterile environments, not like the oral cavity. So we know who the enemies are. There shouldn't be any bacteria in there, right? And in the case I spoke about today is largely about Staph aureus. There are a few others that are quite virulent that we deal with. So that's step one. What are the antibiotics that are most effective against those? And then how do we modify the chemistry of those antibiotics so that they can be targeted to the bone interface where the bacteria are? So that's one of the approaches. The second is the host. Some people you just can't infect. I've heard it many times at this meeting today. She's a 50-year-old, 70-year-old, right? You all have patients like that. So what makes them? What makes their protoplasm so great? What makes their host immune system so great? Well, we're learning that information too now. And so in the case of orthopedics, that's really morphed into ideas of vaccination, particularly at high-risk groups. And that's the other area that we're working on.
You showed through some pretty sophisticated research that the antibiotics cannot get to the bacteria in these canals
At an effective concentration.
Yes, it gets there, but it's not high enough.
Right.
And yet that first one that it touches, it strengthens that cell wall.
Correct.
So it actually makes it worse.
Correct.
Yeah, speak to that.
So first of all, you have to understand that antibiotics come from funguses and other microbes that also fight off these same pathogens, right? So there is a relationship between those two microbes, and the virulent pathogens that we're dealing with have these defenses against those microbes as well. So the antibiotic response of bacteria is evolutionarily conserved. And so when they smell it at a concentration that won't kill them, they put on their coats and they protect themselves, and it takes much a higher dose to kill them. And so the challenge in getting the native antibiotics in the bone at that high dose that will kill them is very challenging. And that's what we're working on.
And that's what you're working on. And from what we've spoken and seen, that you're actually taking advantage of a different class of medications, right? The bisphosphonates.
Correct.
In order to get these medications where they need to be.
Correct.
So talk a little bit about that. You're where are you in the process with this? Kind of how might these work?
Right. So bisphosphonate is a class of drug. It's most well known for use in osteoporosis. Most people don't know that there are these things called bone scans where we look for tumors or infections with technetium-labeled bisphosphonate. So there's two different kinds. The kind that we use for osteoporosis has nitrogen in it. It will kill osteoclasts and some other bone cells. The technetium-labeled bisphosphonate doesn't have it, so it's completely innocuous. but it's the bisphosphonate moiety that binds very, very tightly to resorbed surfaces of bone. And so that's the one we use. And so we screened all of the known FDA-approved antibiotics to see which ones are best for MRSA, methicillin-resistant Staph aureus, what we deal with in orthopedics. And we conjugated the non-nitrogen containing antibiotics to that and demonstrated that for the first time, we can get an antibiotic in these canals at an effective dose that will actually kill the bacteria there. So that's the first advance, yeah.
And so I guess then we start to think about how much of a game changer that is in your world, and how that could change, therapy for these patients who otherwise could face death, could face, a wheelchair for the rest of their life.
Well, just recently, I had a patient that is not a patient of mine, but someone that we know mutually had a knee replacement. Goes back to the hospital a week or so after surgery, and there's an infection. They have to put a line in, and for sure he's going to be on antibiotics for a year.
Right.
And not to mention the IV antibiotics. And so it's just like all we're doing right now is throwing antibiotics at a problem that really is almost impossible to get to without some other mediation. Some kind of piggyback really is what you're using, other medicines to get in there. Dentists are so afraid of bisphosphonates.
Rightly so.
Yeah. Speak to that just a little bit.
So it's interesting. You guys asked me, why I came to why would an orthopedic researcher come to an oral surgery meeting? It's because nobody knows this answer. So for example, since you're throwing antidotes, my wife had to start osteoporosis therapy at the same time she had an abscess that was treated. And so here's an ideal case where she actually has a choice. Should she be on the antibiotics? So these are the Forteos that grow bone. Should she be on the antibiotic therapy, Prolia? Should she be on the bisphosphonates, Reclast? And I figured that you guys would have all figured this out. And yet at this meeting, I did not hear a consensus opinion. And so the reason we're all afraid about it is that these bisphosphonates, their job is to eliminate osteoclasts, which prevent bone loss, but they also prevent bone modeling. And osteoclasts are critical in our normal daily activity. We have micro damage to our bone. Those osteocytes I talked about died. They have to be replaced by live ones by osteoclasts remodeling that. And so if you don't have osteoclasts, then you develop what's called this frozen bone. And as I mentioned, the bacteria know, since that osteocyte lacuna space has been vacated, they may have the chance to crawl in there. And it may actually be opportunistic infections, not necessarily the most virulent ones, MRSA, because the osteocyte isn't in there to repel them out of the vacant spot.
Yeah, it makes sense. And I think when we start to think about how in your world of research, using the, if you will, the good bisphosphonate versus that, it's changed our thought process, because I don't think that's even something I knew, that there were the different types, know. But I thought, before we started, we were talking before the show, and you said, we were talking about revisions, and you made a great, interesting point that I think, we don't think about as much, which is, in orthopedics, there's often not an option like there is in implant dentistry, where we can say, well, you know what, this is failing. We have an infection. We can remove the dental implant. We can, debride the area. We can bone graft. We can allow for healing, evaluate that, and then come back. In orthopedics, often it's a single stage. We've got to get this patient mobile. We've got to get this patient healed. So the pressure so in our world, we're trying to figure out these trigger points. The decision tree, as we were talking about before the show. What is the time that you remove the implant? What is the time that you try to treat it with therapies like what we're discussing in your world? And talk about the importance of developing those types of decision trees and consensus statements. You mentioned some of that during your talk. Right.
So biomarkers are becoming more and more important to utilize to understand that the condition the patient is particularly in. So there's acute infection. It may go away by itself. There's maybe a little more deeper acute infection. You could treat it with antibiotics, maybe debridement. And then there's chronic infection, which can only be treated by extensive debridement and prolonged antibiotic treatment, as was discussed. Where is this patient at? And so we are now looking at biomarkers. I think, before we were on, we were talking about pro-inflammatory markers. Actually, to make your head spin a little more, the more predictive ones actually are the checkpoint inhibitors that are used in cancer immunotherapy. So the immune system basically has these buttons to go forward or stop. And in the case of infection, the immune system has to, at some point, has to make a very important decision, which is, this is an acute infection. Do I call up everybody and go after this infection, but risk what's called cytokine storm and sudden death from toxic shock syndrome by launching all the nukes? Or do, we have to set up a perimeter. We establish a sequestrum, and we turn off the immune system. So where is the patient's immune response?
Right.
And in case of the debridement procedure, you're eliminating that barrier and you're starting all over again. But those biomarkers tell us what stage the patient is at in terms of the severity of their infection.
So is that the focus now, in terms of, you mentioned biomarkers, is these other markers that maybe we don't even know about?
Yes.
You're seeing more correlation
Correct.
with like a pro-inflammatory state.
Correct.
Interesting. And so is that something that's generally being used now, or is that something in the research stages?
That is in the research stage, but it's because of the development of these checkpoint inhibitors for cancer immunotherapy. There's a comfort level with them, and again, because some of these infections are so severe and life-threatening, we tend to be...
That's the holy grail, is to be able to do some type of either salivary or blood testing or whatever and say, you're not going to be a good healer in this situation. Or the next level to that is maybe to develop therapies that could turn you into a better healer through down-regulating the same things that are going crazy for whatever reason.
Right.
And I think about this with COVID, which is, I think, got a lot of us thinking about why you could take, 1,000 patients that seem to have the same medical history, and yet we see long COVID, and we see acute, and we see cytokine storm, and yet it could be complete. It seems, at least from my limited knowledge, in that it's not homogeneous. It's not the same.
It's patient specific.
Yeah, and so everyone's trying to figure out the why of why some people react that way.
Yep.
And it sounds like you're right in the middle of that in your world as well.
We all want to show up, see a patient, make a good decision.
Yep.
And it's collaborations with and consensus statements with other team members across the world. It seems like that we should have been talking a long time ago.
Yeah.
It's like, okay, why? And it is hard. But you even mentioned a paper that where the FDA saw that this wasn't working, because you looked up like, oh, someone's done that. You were looking at a particular marker. And I think, man, if we were just all communicating, the cancer people with the oral surgery people, with, the immunotherapy people, and working together we all want to be working together for a common good, which is for that decision-making capacity for that physician and then the patient to be able to understand something.
Right.
You mentioned something that happened even in your journey recently that helped a doctor be able to take his patient's knowledge to maybe an understanding of what was going on. Speak to that.
Yeah. So I think another buzzword in all medical procedural fields is shared decision making. So it's not just collaboration of oral surgeons and orthopedists. It's ultimately collaboration with our patients. And in the cases of oral surgery that I hear, where there's so many options to be made, bone grafting of so many different types, different implants. How are we going to make the decision for this particular patient? Costs obviously figure right into all of that, money and time, risk benefit. So I think that's really where we should be moving together as a society, and big data science
Mhm.
and AI is coming on very quickly, so that things that we know about, for example, pro-inflammatory markers, microbiome, checkpoint inhibitors, things that we know, but it's like, well, I'm never going to be able to do the math on that on my patient. Well, soon we will.
Yeah.
And we talked before, is essentially that's how we decide whether or not to take medicines for lipids, is based on a risk factor, not by a definitive number. And so ultimately, that's how we will figure this out.
And I think that this conversation kind of leads us back to where we were talking with Todd earlier, one of our other guests, about the idea of translating research to clinical. And, in our field, that's been challenging because we have a lot of things where there's sort of a 510K clearance, meaning, we've just got, this is a device, and so it doesn't always have the data, which we are trying to push for more of that. Do you have similar challenges, do you find, in the orthopedic world, say, with translating a lot of the basic science, the clinical research to the clinician?
Yeah. So I the best examples of this in total joint replacement, and why the consensus meetings really started for us in orthopedics, I think we were happy to just go along, is healthcare reform. So so the healthcare reform that happened during Obama, they came after the orthopedists first, because these are the most expensive billing codes Medicare reimburses, total joint replacement being number one. And so we arrived at a bundle, which is a single dollar number per procedure that includes all complications that will happen related to that, or even just the health of the patient in general for 90 days. So we had to have science, right?
Gotcha.
We really couldn't as a field just do things because we always did them. And as I mentioned in the consensus conference for antibiotic bone cement, it was a little shocking for a basic scientist to me to hear every surgeon in the audience uses antibiotic bone cement, but none of them believe it works, right? So it's as a physician, you feel defenseless when there isn't something in there. There's this need to do something, and I think as a scientist, one of the things that moves the field is taking away the something that we know doesn't work.
Sure. Well, I think
that's what forces the innovation to come.
Progress.
And that's what happened in orthopedics.
Well, we're hopeful,
Yes.
I think, in our world, because we have not had that event of, say, healthcare reform that has come in and said, here's what you're going to get paid, and we've kind of talked about that on the show in years past, and we kind of fear that idea of just saying, we should be getting there on our own by self-regulating and saying, hey, if these are things that we don't have data for, we've got to have that.
Science and clinical, practice and all these things start to compound in decision-making capacity. If we disregard one for another, we really don't have great solutions.
Correct.
And going forward, I see more collaborations like this happening. I see more communication. There'll be government agencies like we talked about, the Surgeon's First Report on Oral Health in the year 2000.
Exactly.
And people like yourself that see the need to be a scientist.
Yep.
And I love science. And I love whenever I look across the room at someone like yourself and it's said something to me. And maybe not today, but I need to keep my ear to the ground and pay attention to really what's going on in that field. Come to organizations like this where we can meet people like yourself and really understand how things are going to get better.
That's right. Really, in the end, that's why we're here. That's why we're talking, is because we want to have an evidence-based practice. I know those are words that are thrown around a lot, but it really is true. We've got to question everything we're doing. Is it proven? Is it something we're just doing because we're doing it? And how interesting that, something that I guess I would have assumed, like joint replacement, would be sort of, data-driven, standardized up until, you have all these surgeons. We do this because we just do it.
Right.
And we have the same thing. In our world, we do it because someone told us to, and that's what everyone does, and we're not asking questions.
Change is hard.
Yeah.
Regardless. And hopefully the change for the future is really what the AO's been here to do and say this week, going beyond the boundaries. Our boundaries before shouldn't be our boundaries now. We should look beyond the boundaries.
Well, you've challenged us a lot to think about things differently, and we really appreciate you being with us today.
Great. Thank
Yeah.
you.
Thank
My
you so
pleasure.
much.
Thanks for inviting me.
So if you're liking this and you're liking what you're hearing here, John, I'm loving it. And it really doesn't get much better than the Academy of Osseointegration annual meeting. And for Edward, for John, I'm Wes, and we are the Dental Guys.